then are not lost as a result of this cutoff. HRH is always one of the motive issues. So there are so many things that we need to discuss under human resource for health, including the community health promoters, and of course now the implementation of primary health care, where are we, and the like. The other critical one, Your Excellencies, is about MPDSR. You've realized in the recent past that we've seen in the papers, we've seen in roadside pronouncements, and of course even from the highest office, about maternal deaths and newborn deaths. As the duty bearers that are charged with the responsibility of health function at the counties, where are we in terms of MPDSR? And the Council of Governors will be giving you a status update of what we've done, so that now there is buy-in from the highest office for us to be able to bring maternal and perinatal deaths down. Then lastly is on the programs that we are running. What are those programs that we have at the counties, so that all of you excellencies, as the people charged with the responsibility of running with the health function, then you are well aware of the projects and the programs that are currently running in all the counties. And once we do that, I tend to believe that we will be able now to release our resolutions. And of course, looking ahead, we have the summit that is coming up on the 10th. As a health committee, which has a lot of things in between, what is that report that you'd want to take to the summit? And I think, Your Excellencies, this meeting accords us an opportunity to be very candid on what is happening in the health function. We need to be extremely very honest with ourselves. Let's speak as it is, so that as we now go to the summit, then our message will be done, will be heard. I had a meeting with the health committee this week, and of course, after evaluating how we've been able to deliver our messages at the summit, I tend to think there has to be a shift. Chair Health, I'm addressing you and the governors. For the last 10 years that we've had summit, I sat down last week for almost 2 hours alone, and I asked, what is it that we've done wrong that are in most instances, the summit resolutions are never achieved. And in most cases, the most critical things are not addressed in details. What is it that we can do differently so that some of these issues can actually sit well with the highest policymaker? And one of the things that I thought about is this time round in the summit, and in as far as health function is concerned, we need to have a shift a little bit. And the shift would be, we don't focus really much on financing, which of course is nothing that comes without financing, but we focus on service delivery. What is it that is critical in terms of service delivery, and what is hampering service delivery? If SHA has issues, what are those real issues with examples? Real things, because you're the people that are running the health function. What are those issues, real ones, with examples, so that at least we can change even the emotions? Then after we do this, after we address the issues of service delivery, financing will follow. Warren Buffett said, money does not follow a plan. You define a plan, then money follows a plan, not a plan following money. So we need to have a plan, we need to hatch our concept, and we need to have a different delivery in as far as health function is concerned. So with those much remarks, allow me now call the chair. Do we have Gerald on call? Allow me now call the chair of health committee, who is also the host governor, to welcome the governors in his county, and of course give remarks so that we can proceed, and he opens for purposes of proceeding. Thanks. Sorry, and you recognize the governor that is online?
I think we get Gerald. Is he online?
I am online, Your Excellency.
Yeah, please, Gerald, asante sana for your support. Maybe we also get to hear from you.
Yes, Your Excellency, thank you very much. There's a bit of an echo in the background, but allow me to make some quick remarks so that we can all get started. First, Your Excellency, newly elected Chair of the Health Committee, DOG, Your Excellency Abdulswamad Sharif Nasir, Governor 001, Excellency governors present, including those online, and also CEO of the COG and the staff at COG, distinguished ladies and gentlemen present, including my fellow development partners, if there are any there. First is to congratulate this committee for your election into office. I think this is sort of the final term in this period before the next elections come, and we probably have a new set of leaders. So congratulations, you have to finish this term well, and I'm sure that you definitely will. This health committee has probably the biggest task amongst all the health committees, amongst all the committees in COG, because it's the one minding the affairs of a devolved function, the function that is fully devolved, as the CEO has put it. And so it's not easy work compared to other committees, and I commend you for the work that you've done, including Governor Mudomi, who was the previous chair, who did a very good job. And it's good to see that he's in the room so that he can pass the baton comfortably. And I'm sure, Your Excellency, you will do an equally good job. We at the Clinton Health Access Initiative, CHAI, we've been with the counties since the beginning of devolution in 2013. We were there working together with all 47 counties. We continue doing that. So you can continue counting on our support to continue working with the Secretariat and with you and with the CC caucus and the other members of the county governments that we work directly with. That we will continue doing. I think looking ahead, there are a number of issues, as CEO has outlined, that will be critical, and especially as the funding landscape has significantly changed with the departure of the US government and the issues that need to be dealt with across all the strategic programs, whether it's HIV, TB, malaria, family planning, immunization. Those are all strategic programs that are handled at national level, but the execution is down at the counties. And so the active conversations that need to be there with the national government around those programs and how the funding landscape has changed and how it affects the counties, that is a conversation that becomes part of your agenda. I think the second big agenda item is the question of whether all the counties are on track with FIF and necessary execution part of FIF, whether that is working out okay. And especially now that there is funding that is flowing directly to health facilities that are empaneled within SHA. I think the third item, which is again critical, is on health products and technologies. KEMSA is finalizing a strategic plan going, I think, into the 5 years. It's important for this committee to engage with KEMSA and find out what is in the way health products and technologies will be flowing down from KEMSA to the counties, and what changes from previously there. And obviously at this time when KEMSA has already been given a credit line of 10 billion shillings, how will that function? I'm not sure that they've finalized on their strategic plan, but they've been working on it. We've been helping them to put it together. It will be good for the committee to engage with that process and find out what is going to be different. And finally, on SHA, where where the COG has sent me as the representative on the board, this is to report that we have finished the recruitment process of all the directors and assistant directors, and principal claims officers. Those were the critical positions that needed to be filled very, very quickly. We've already done that. And we're in the process of recruiting county coordination staff who will be situated at the counties, working with you to make sure that any business that has everything to do with SHA, you have people next to you that will be resolving those matters as they arise. And of course, I would urge the committee to keep engaging with that process. The Secretariat gets a flow of information from SHA, and I'm always available to shed light on any issue that may be arising out of SHA. Of course, being a board member, I'm restricted to only governance issues, and obviously the operational issues will always be handled between the COG Secretariat and the SHA management. There are two of us there representing the counties, including CEC Roslyn, who is also sitting with me in the SHA board representing the counties, and coming from the CEC caucus, she also has an opportunity to do as much, to be available for as much briefing as possible. So with those few remarks, Your Excellency and Excellency Governors, I thank you for this opportunity to make these remarks, but also to commit the continued support of CHAI for the committee and for the rest of the work that is going on in all the 47 counties. Asante sana, and God bless you all.
Thank you, Gerald. I think a lot has already been said by our CEO, and equally, Gerald has raised the issues. I also want to confirm that we have online Governor Sang, Governor Tichilo. Is there someone else who's online? Is it just the two of those? Yeah, and I'm aware that there are others who are online, and we just need to be able to confirm that they can be able to join us later on. My fellow colleagues as well who are here. The issues that have been discussed here, I think what we need to be able to come up with is not just resolutions, but what happens after those resolutions. These discussions have been going on for a very long time. One, the issue of SHA, we're having a problem when it comes to reimbursements on time. Two, I know that there are issues that are there, and this affects everyone here on matters of how long it takes for them to be able to confirm what has been rejected, what has not been rejected. Three, does it become one-sided in the event that something gets rejected? Is it all totally just one-sided without having a say on the other side? Four, do we have a window to be able to appeal on those particular rejections? And most importantly as well, is the fact that if you put in a claim today, how long it should be able to take for them to confirm that yes, this is on the amount of money that needs to be paid, and what is already been rejected, so that you don't wait for months on, and then later on is when to be told that this is something that has been rejected. The other issue, and I'm sure that we'll be able to deliberate on those matters, we need to, immediately, whatever it is that we deliberate here as a committee, we'll need to forward it to the full council for endorsement on our proposals, so that we can now further it at the summit level. And when we go to the summit level, I agree with what Mary has said. Everything takes a rejection plea, and if you saw what happened at the last IBEC, where things were brushed very, very quickly, So what I propose that we will do, for avoidance of doubt, is whatever it is that we discuss here, we forward this as well to the ministry. I had a conversation with the CS, and the CS has indicated that whatever it is that we deliberate here, we formally forward it to them, so that we set a time where they can now be able to answer all those issues, or we now tell them that we come on board, because everyone has to be able to respond to these matters. To the issue of NESP as well. We're all having problems. In fact, there are some companies that have not even supplied anything, and they've been blessed to have a very, very lucrative contract, but they've not been able to supply. The committee will need to be able to make a decision. If Mombasa alone has 47 facilities, together with other outreaches, I'm trying to imagine the number of facilities throughout the whole of Kenya, cumulatively. And we cannot be held at ransom if people do not. So we need to be able to come up and agree as a council on what are going to be the timelines for these deliveries to be made, failure to which then every county can be able to do what needs to be done. The issue of the human resource, of course, the UHC staff, it's now taken political turn. I've seen that national government has indicated that if the counties do not absorb them, then national government will absorb them, which I don't know about you, but just today alone, as I was driving from my office to here, I've received 2 calls of doctors asking for jobs. Last night I got one person as well. We need to be able to do this in a proper way. It is understandable that we need to be able to employ these people, but counties need funds. If those funds are not going to be there, and Treasury is not going to be able to budget for those funds and is not going to pay those funds, it becomes a challenge for everyone. The issue of the CHPs, I am aware, of course we're all aware that they've already budgeted for those particular amounts. However, transfers need to start taking effect on the same. PHC, another challenge, and the proposal that I will be doing, Mary, is we not only get the CECs to do the report that has been put up in the last page, where what is the amount of PHC that has been paid, what is pending and all, but then get every governor to count in on that. And what I'm proposing as well is it has to be in more detail, to the extent that if it is Baringo, what are the facilities? Which facility has a certain claim? How much has not been paid in every facility? So we provide this information, and we even give, if every facility has a unique identifying number, we send it to them with those unique identifying numbers, the name of the facility that has been registered, so we don't leave anything to chance, because if we set this to them as a whole sum, then it becomes another issue altogether. The financing, of course, now we no longer have financing at a number of donors are pulling away. USAID, Danida is more or less on its goodbye stages, and we need to be able to now start thinking as a county team. There are programs currently that are there, and we need the Secretariat to provide advisories to us. I know that there's some programs that have been discussed a while back, the World Bank programs and all, but I'm seeing that because a number of you have the KDSP programs, which counties like Mombasa are not with, but you will realize that you're seeing a lot of people from the ministry starting to take effect on this. Programs like FLOCA, which are World Bank funded programs, but then the ones from health, we're yet to see because the ministry, without the ministry pushing, then we cannot get an equal allocation or a good allocation from Treasury to go to the departments of health. on these particular matters. And I know that there was a program that had been discussed a while back. We need to be able to figure out a way of reviving it, either considering it's at advanced stages, either through a supplementary that national government will be doing, or the next budget, which we all know what is going to happen after June next year. I don't think any governor is going to be sitting unless those ones who are on their second term, everyone else will be on the move. And of course, the other part is the issue of the MPDSR report, which has also been very heavily politicized in many cases. We also want to try and see when deaths are recorded, the MPDSR, also what are the normal occurrences vis-a-vis what is the workload on that facility that reported that, and equally, what is the normal deaths that are reported in that system as well. And lastly is the issue of the building resilient and responsive health system. So it's going to be an exciting time. I think we need to be able to get guidance, because we have 2 representatives at the SHA board as well. And we need them to be able to tell us. One of them is, of course, the one from the caucus, and the other one is Gerald. And there has been a feeling from the governors as well. Their issues are not being properly deliberated at the SHA board level. So it is important for us to also call in and we ask them what it is that has transpired. How are they handling these particular matters? So whatever resolutions that we agree on SHA here, it is important for us to equally get our representatives to tell us whether they were actually deliberated, were they not deliberated, what was the outcome of those deliberations, and so forth. And lastly, we need to make a decision, because I think we need to be able to have a vice. But considering the numbers that are there, Gladys had always been the vice chair. Whether we need to be able to consider, because she's currently, I don't think she'll be able to be online because she has guests in her county as we speak right now. Whether we need to consider maintaining her as the vice, the wisdom of this committee, we'll need to make a decision as we move forward. Asanteni sana. I think considering we're not very many, the ones that I was able to introduce, the rest for being on record, I did mention those ones online. But maybe, can you hear Sang and Otichilo? Governor Sang, Governor Otichilo?
Yes, Chair, I can hear you.
Okay. That is Sang.
Yes.
All right. Thank you for being on record. And Otichilo we saw him with a red tie. I'm assuming he can hear us if we were able to see him. So I'm sure he'll be able to join us in the deliberations. Maybe we get the other governors who are present here. I think his system is hanged, that's why.
Thank you, Chair. Muhammad Khalif, Governor, Mandera County.
Mwadhami Njuki, Governor Tharaka Nithi.
Benjamin Cheboy, Governor Baringo.
Good. The issue of the vice chair is something we need to be able to agree on. I had proposed whether we can allow Gladys to be able to continue as the vice chair. Do we have concurrence? I'm sure she will not have an issue. If she does, then we will now have to raise it in our next meeting. Is that fair enough? I did have a word with her, by the way. She seemed that she was okay. Yes, Sang.
Chair, I think your proposal is fair. We need some level of institutional memory and continuity. Therefore, you being a new, not new in the committee, but being new in the leadership of the committee, having Gladys to proceed to continue serving as vice chair would give us the necessary institutional memory. So I second you on that.
Will be formally notified by the by the secretariat. Can we go to the presentations at hand?
And the chair, just one small point from myself here.
Go ahead.
So I will continue following and participating in online, but sometimes the online engagement can be difficult. I missed my flight this morning. My apologies, I was hoping to be there personally. So there was a session that I was supposed to moderate. I wish to make a request that my colleague and Governor Baringo can do it on my behalf, so that I am able to just follow the proceedings and I can still participate. But that responsibility be handled by Cheboy. And graciously accept.
Yeah. Cheboy, you okay with that? Okay. We didn't introduce the other governors. They've not introduced themselves. Maybe... okay.
Thank you so much, Chair and Excellency Governors present, my CEO.
Kathra, before you go on, just a quick one. We have an apology from Governor Waiguru. Maybe just minute that down as well. Thank you. Go ahead.
Thank you, Excellency. So good morning once again. I'll quickly take you through the emerging issues in health as we are going to project. And Excellency Governors, I know health matters are order of the day. So as much as we are just taking you through some of the emerging issues, I know you already know some of them. And I will just quickly take you through updates, status update. Jemima, you can help the person projecting. So as the upload is coming, I'll just continue. Some of the things that we are going to discuss today in terms of outline is update on the CAG Health Committee membership. Before we were actually 19, but now with the new membership we are 11. Then social health insurance, National Equipment Service Program, health financing in counties, human resource for health. Then we have to discuss also community health payments, the CHPs that is, primary healthcare implementation in the counties, strengthening MPDSR at the county level, building resilient in health system and the NIDA program. These are some of the things that we are going to discuss this morning. So Your Excellencies, these are the new committee members. Maybe next. These are the new members of the Health Committee. We have 11. We have Your Excellency Abdul Samad, Gladys Wanga, and I'm glad that he has also been endorsed as the Vice Chair. Then we have Her Excellency Anne Waiguru, Wilbur Otichilo, His Excellency Muthomi Njuki, Fernandez Baraza, His Excellency Stephen Sang, Dr. Kimani Wamatangi, His Excellency Benjamin Cheboi, His Excellency Jeremiah Lomorukai, and then His Excellency Mohammed Khalif. So we have 11, and CEO said this morning she may add more to this committee. So, Your Excellency, just a quick update on status of social health insurance. And I know we've been having this discussion at council level and also at the summit many a time. So the service delivery is a core mandate of the county government, and we all know that. And consequently, the reform in the health insurance through the implementation of SHA has gaps that negatively impacted on service delivery for most of the county health facilities. Most hit are level 2s and level 3s, and the issues around the level 2s and the 3s include the restriction of services offered by levels of care, particularly maternity services at level 2, and the transition from Linda Mama to a complex system under SHA that further restricts maternal care. So, Your Excellency, there was a directive that level 2s and level 3s are not supposed to conduct deliveries. And even recently, that was yesterday, we had a case in Tana River where a mother who was referred from a level 2 facility actually passed on when she reached level 4, because the only facility that was nearby was a level 2, which could not offer that services. And in the process, because she was bleeding, we had to lose her. So that is one of the things that we have, and I remember in the consultative meeting that we had with the council, CS Duale was actually to revoke that directives which came that mothers should not deliver in level 2. That is one of the things that has majorly hit the level 2s. And also the issue of Linda Mama. Before we used to have Linda Mama, which specifically actually ring-fence mothers as a walk-in, walk-out client. But as we speak right now, it is the Inua Jamii. So mothers actually have challenges in terms of insurance cover under SHA. And you've seen what has happened in Mama Lucy, where mothers could not be able actually to pay for this maternity services. So in level 2, we also have frequent system update without adequate notice and capacity building of the users. So we have system in place, but there is a gap in terms of training. So as a result, then that also affects service delivery. Then we have restriction of access to services to public servants under SHA. And I know even during IBEC, that is something that we basically discuss. Under SHA, so we also have that issue of county staff. As much as like it is a guarantee that once they get their salary, the statutory deduction will be done, still by 9th of every month, if that statutory deduction is not submitted, then that means they lose out of the cover. So it is something that was also discussed at that high level, but not addressed adequately, and it is really affecting healthcare workers under SHA. Overall, SHA implementation has not factored in the need and diversities that come with geographical and technological capacities in remote location of Kenya. This needs to be addressed also progressively. And when you see the counties that are not basically doing well are basically the ASAL counties. So our recommendation here is both levels of government to work together to address the points, these issues, so that the citizens and healthcare workers can all be able to access SHA, and the healthcare workers who are providing services can also be able to benefit under SHA in terms of their medical cover. The other issue still under SHA, Your Excellencies, are level 4s and level 5 hospitals across the counties, which are actually at the brink of service delivery paralysis as a result of offering services but not getting adequate reimbursement. While some facilities have recorded an improvement of the fund reimbursement under SHA compared to NHIF, major hospitals have unpaid debts. So for example, Makueni County Referral Hospital have been paid 10.1 million, and they have 100 million actually pending. Homa Bay County has been paid 27 million. They have a pending bill of 79 million. Kisumu, the same. In the last 3 months, they have been paid 700 million, with Kenya shilling 176 million still pending. And this is not only on the facilities that I've mentioned, but many facilities within the counties have been affected. Overall, we have close to 9.6 billion, which has not been paid by SHA. A sample of 4 counties actually revealed that 1,400 claims that worth 64.7 million that was rejected by August 2025. Specifically, the random four were Mombasa, your claim, Your Excellency, the chair, of 12.3 million was rejected. Garissa 23.4 million was rejected. Kirinyaga 12.6 was rejected, and Kisii 16.4 million was rejected. So we basically picked on a few sample counties to represent the entire 47. As a result of these debts, facilities are unable to replenish consumables, pay suppliers, and also maintain the standard of care in the facilities. So here our recommendation was SHA to pay facilities the pending claim for continuous, so that we have continuous service delivery public health facilities, address the issue of rejected claim. And I remember, Your Excellency, Chair, when we were with you in National Assembly, you raised this one. And the National Assembly also raised the same in terms of rejection of claim and poor feedback in terms of timely reporting back to the facilities. Then SHA also to consider reimbursement of rejected claims, and that the resubmitted claim should be evaluated and verdicted provided within a specified time frame. Your Excellency, the other issue is on SHA, and the SHA is still, I mentioned, is about the healthcare workers offering services across counties, and they cannot access the care past the 9th of every month. So, like, we have officers who have been going to facilities when they want to access, but they are told your SHA is actually, your medical cover is inactive. And this act actually restricts service provision to county public servants who are mandatory to SHA is guaranteed. The reduction is basically guaranteed because once they get that monies, it is obviously submitted. This is despite the fact that there is solution obtained for the national public servants. So, like, we have two categories of healthcare workers, the national and the county. The national officers are not affected, but the county officers are basically affected as a result of the delay. And remember, this is as a result of also delay in exchequer. So, 908 public health facilities, as we speak right now, have not been enabled to claim due to lack of tablets. And sometimes officers are forced to use their tablet, their smartphones, which is on-off. So as we speak right now, when we analyze, the primary healthcare facilities, 908 cannot be able to claim. So these facilities are forced to either use their personal gadget for service delivery or forfeit claims. The facilities continue to offer free services but cannot benefit from primary healthcare fund. And many a times as council, we were able to basically write to the national government giving them this number of facilities. So the other issue is about internet connectivity and network availability in hospital. We've just received letters this week. I don't know, because as a result of the upcoming summit, they want us to continue giving them facilities that are not connected. So every time we submit data, but nothing comes through. But when we are nearing summit is when you see like things are flowing right, left, and center. So the shift to digital claim across all levels of care without establishing requisite infrastructure has impacted the performance of facilities, particularly primary healthcare facilities in rural areas. Even when issued with devices, still there is going to be network challenges. So some of the recommendations probably on the healthcare workers is like the national government to come up with a mechanism to provide medical cover to public servants amidst delay in remittance by counties. And then in terms of tablets, Digital Health Authority to provide devices to affected public health facilities to enable them to claim for primary healthcare funds. And then in terms of internet connectivity, the national government to fast track installation of internet in public health facilities and upgrade network coverage for effective service delivery. The other challenge in terms of primary health care facilities under SHA, county public health facilities have received 57% of reimbursement. That's Kenya shilling 4.9 billion of total primary health care claims. So facilities cannot be able to know what they get back because it doesn't show. They cannot be able to see, access they cannot be able to access what was paid for. Probably they are providing outpatient services, but specifically when you break it down, as much as they get reimbursed, they don't know what has been reimbursed specifically. So at the facility, the officers cannot tell how much they have claimed per outpatient visit. With such a challenge, they cannot be able to optimize their claims. So they just get pool of money, but not broken down into specifically what and what and what. In terms of maternity services, Your Excellency, I've just mentioned the level 2s and the level 3 facilities. They have been pivoted, they are very pivotal in enhancing availability and access to skilled maternity service, contributing actually to 24% of deliveries. That is cumulatively 256 to 38. And right now what is happening, because at those level of care we are not providing maternity services, we are basically going back to where we are. So skilled delivery basically will drop. Mothers will not go to those facilities because they know where I used to deliver. If I don't deliver to the next facility that is near me, I rather deliver at home. So then that means skilled delivery will basically reduce, and we have already reports on that. The gazetted benefit package also limits maternity services to SHIV, which cannot be used in level 2 facilities. As a result, these facilities have missed out on at least Kenya shilling 2.6 billion as reimbursement from delivery. These primary healthcare facilities are supposed to be getting 10,000 Kenya shillings for every delivery, unlike NHIF where they used to get 2,500. So as a result of missing out, as a result of the directives, cumulatively these facilities can be able to miss out around 2.6 billion for only deliveries, because mothers now have to go to the higher level to deliver. The move to restrict maternal services at level 2 facilities also risk reversing gains that was made in terms of skill delivery, and even further for the last financial year nationally, there were a drop in performance from 89% to 72%. When you look at the Kenya Demographic Health Survey of 2029, skill delivery was at 89%, but right now as we speak, it is at 72%. That is a drop in regards to the facilities that were basically supporting in this skill delivery, like the primary healthcare facilities. Counties like Kisumu have actually dropped from 89 to 69%. Nairobi has dropped from 100% to 80%. So that means we have really gone down in terms of skill delivery, and whatsoever I'm actually mentioning here is the facts from the counties themselves. And this is as a result of specifically, again, level 2 facilities. So there is need for, therefore, in terms of recommendation, for clarity of the weighted billing and reimbursement for outpatient visit in primary healthcare facilities. This enables the facilities to plan knowing how much they are expecting. SHA also to allow level 2 facilities with delivery beds to offer and claim for maternity services, including refund of 2025 deliveries, which has not been done. And then government also to consider having maternity services under PHC fund to make it universally free and accessible. A mother who is used to getting those services nearby her house, because every 5 kilometers there is a health facility, who is used to delivering in those facilities, if she's told go to another facility, obviously she will not accept. So then that means now they'll just go back to the TBA, and then we have more and more unskilled delivery. Still under SHA, Your Excellencies, the issue of the National Ambulance Dispatch Center, and I'm glad that Governor Mudomi is again here. The last time we had a meeting at the National Affair House between the Health Committee governors and the CS Health, the agreement was like the CS Health said he wants to meet with the governor so that he can be able to explain to them about national ambulance services and the emergency and chronic, but it never happened. So right now, MOH through SHA is processing and operationalizing a national ambulance dispatch center, which will be hosted at the SHA offices. And I don't know if this will work. And right now they want us to convene as technical so that we see what will work and what will not work. But the meeting that we just had with SHA, the technical team, and also the CEC's caucus, the CEC's caucus said categorically that this may not work. Ambulances cannot be able to be controlled at Nairobi when, like, the counties are far, already have an established system and things are already running. The proposal was like, how can we be able to integrate those services? And then still, there are so many issues around the ambulances because they come up with so many guidelines on what is required in those ambulances. Then that means still county ambulances will be able to be locked out. So, Your Excellency, the Council unanimously agree that implementation is untimely due to unclear description of what entails life-threatening emergency. You cannot dispatch an ambulance from Nairobi to probably Kisumu, but the Kisumu people already know where the patient is and they can be able to respond adequately. Then the standard for ambulances and personnel are not quantified. There is unplanned cost for counties in procuring GPS and monitoring system. They said like all the ambulances must have a GPS so that they can be able to monitor and dispatch. And there is also risk of making ambulance services more of business than service delivery, because every person or every Kenyan will be able to look at this in terms of business, and there will be a lot of procurement of ambulances that now will outride what is already existing in the county. Then funding and funds implication as county await payment up to Kenya shilling 3 billion in shared debts. Then there is risk of duplication given that counties already have dispatch centers that are operating emergencies. So ambulance dispatch center, the recommendation is that the ambulance dispatch center need to remain decentralized because health is a devolved function. And this is basically because local governments know better the geography, and they need a language for the community. As a result, the council has also issued a letter to counties halting county registration of ambulances at KMPDC until that is now going to be resolved at the council. And then a mechanism of addressing all raised issues by counties need to arrive. We need to arrive at that consultatively before the national launch is firmed up. And we were told that there's going to be a launch 1st of December of those ambulances. All raised issues by counties need also to be conversed and agreed upon before implementation is done. So, Your Excellency, that is it for SHA, and those are the things that have been raised under SHA. So maybe I need guidance on whether we can continue, because the next agenda is on NESP. See you.
Now, there are some 3 issues that I need just to buttress before we move to the next one, just for purposes of clarity on what is happening. Your Excellencies, in terms of these services and, of course, the level 2 and the like affecting the ASAL counties, it is because the ASAL counties, the nature of the expansive nature, that's why they actually decided to invest more in level 2s and the like. And for that reason, if these services are withdrawn from them, then it means they are more affected because their services are more concentrated in the rural areas more than other counties. That's why we are saying in advancing SHA, there has to be differentiated mechanisms on how to treat each county independently. What happens in Nairobi cannot be applicable in Mandera, cannot be applicable in Baringo. So I think MOH must be aware that counties are not at the same level. Counties are different. The expansive nature of the counties force, and especially the ASAL counties, to invest more in level 2s more than any other, because we realize that a level 2, from a distance from level 2 to a level 4 could be even 100 kilometers. So why would they not do that for purposes of ensuring that we close that? Number 2 is when we had IBEC, there was a promise that the gadgets for all the hospitals for purposes of claims would be dispatched by 1st of October. Your Excellencies, right now, the gadgets have not been dispatched, meaning that county health facilities continue to offer services, but they cannot be able to claim back because there are no gadgets. So I think even these, then we need to ask ourselves, to what extent are even those resolutions from IBEC or Summit binding, and to what extent are they implemented? Your Excellency, I was giving the example of the gadgets because we were promised that they would be delivered by 1st of October. Up to now, we have submitted list 3 times, including yesterday. They keep on asking for the list every time. In terms of connectivity, I think there's a game that is going on. Beginning of March, DHA did a survey to ascertain the counties and the level of connectivity in terms of the pipeline, in terms of, what do you call them? Fiber optic and the like, for level 3, 4, and 5. But yesterday we were shocked, we were being asked to give an analysis of the counties without connectivity. We do not have actually the capacity even to know. So what we said for each and every county that is not claiming 208 something facilities, then we assume those are the counties without connectivity. Now, Your Excellency, in terms of policy change, we need to be very clear here. In terms of SHA, people sit down in Nairobi to make policy change without informing the duty bearers who are the counties. And I want to give an example. About these level 2 deliveries and the like, I saw standard on Tuesday, standard on Tuesday. The Director of Health Services saying that they've already opened deliveries at level 2. And we did a quick analysis yesterday in the morning, calling a few hospitals to find out whether that is the case. It is not the case, Your Excellencies. So any change of policy must be communicated to the duty bearers who are the counties. So I think that's what we are saying. Health must not be advanced on political platforms or roadside pronouncement. It has to be tentative. Number 3, is there something that is happening that, you know, even as we have friends at SHA, we were told there's a policy shift in terms of weighted billing. Weighted billing is where they assign a worth. I got a lot of interest, and that officer really gave me clarity. Weighted billing is seated in Nairobi. They say that they've devised a policy on how to weight a service. For example, if it's malaria, they weight it at 0.8. If it's a lab, they weight it at 0.2. So each and every person that comes for malaria, the claim is higher. But remember, the counties are not aware. So that at least we can be able to do predictability and be able to ascertain the claims that you will make, because you do not know what it is. So there is no policy change or change of tariffs and the like without communicating to the duty bearers, because even the counties need to know the exact amounts that they are supposed to be claiming. Lastly, is about feedback on these claims. In IBEC, we say that the reason as to we need to have a consistent way of giving feedback to facilities. If a claim has been rejected, then there has to be a reason thereof, so that we keep on improving systems as we move forward. And it was agreed that there will be a dashboard, if you can remember, Your Excellencies, that there would be a dashboard for the governors and a liaison officer, a claims officer in the counties, so that for each and every claims that you make, after 2 days, then you can actually ascertain, or after the payment is made, you can determine that this claim was approved, this was not approved, and the like. And I think now it's deliberate. And if you look at the reimbursements per facilities, what was a year ago? If we're at 92, right now, Katra, I think we need to project that the analysis. Counties are actually getting 32%. So we need to ask ourselves, are we really improving moving forward? And what happens on these gains that we had already achieved? And for example, the skilled bats. So I think those are some of the things, candid conversation that we need to have at the highest level at the summit, not narratives now. Thank you. Oh, sorry, the ambulance. So the ambulance system, the former chair, we agreed that the ambulatory services is a fully devolved function. Counties had already invested in ambulance services and the like. Some of them have functional hotlines and the like, how to connect their patients with the ambulances at the count level. So this program is being launched on 1st of December. Without any reference to the counties, you remember when you had that meeting, it was agreed that the technical teams will sit so that we understand what there is. Centralization of ambulatory services will be actually a death for the counties. So I think this is something that needs to be addressed quite seriously at that level. Thanks, Your Excellency.
Thank you, Chair. First, let me start by saying congratulations, Chair, for being elected as the Chair of Health. It's quite a challenging docket, but I am very, very sure from your performance in health in Mombasa, you are equal to the task. And equally, I want to report here that the Vice Chair who has been elected, who I want to congratulate, has been very supportive and always available to step in the gap wherever the Chair is not available, and even the chairs are available. I remember the last time she went all the way to Garissa to represent us in a symposium that no other member was available. She was only a member of health. And that I've never forgotten that, because there was a story about the kind of aircraft we used and how scared she was. So She's dependable. You just need to make sure that you tell her in good time, and she'll always be there. Having said that, I do not want to repeat what the CEO has said, but I want to have just a small, not really modification, but an inclusiveness on that issue of dispensaries. We cannot have a two set of policies where one is for the rural counties, another one is for urban counties. I am not the governor of Nairobi, neither Kisumu, or I don't have a city in my county, but I'm trying to imagine that the kind of distance covered in Mandera may literally be the same distance covered in Nairobi because of the nature of the population. If you look at the slums in Nairobi, and you're telling someone to move from deep inside Mathare on an emergency to Mama Lucy, it may become almost impossible. And sometimes you find that is why data is showing that the attended births or skilled birth are even reducing in Nairobi. You should be asking yourself, where are those people in Nairobi going? Because if you told all the mothers to go to Mama Lucy, then Mbagathi, and a few others, the place will be so congested. So what is not for the Kanidi and for Mandera in terms of distances, in Nairobi, it could be the same because of populations. And that is why the level 2s will serve the purpose of decongesting the level 4 and 5. No, everybody cannot afford to go to Pumwani because of probably the congestion. They would have to make a Pumwani that is much bigger than even Kenyatta itself to be able to accommodate all those mothers. So we have to advocate for one solution to every county where the births in level 2s are considered as births. Because it is possible to fake other diseases. You can say I'm having a stomachache, but can you really fake delivery? Because there's a product which is visible. So even when you talk about fraud, how can you have fraud in giving birth? It is not possible, Chair. So we need to have that sorted out by the ministry and not talk about the issue of level 2s not having bed capacity just because they are level 2s. They behave as if it's supposed to be a place where people are supposed to be served while standing and not even leave alone about having beds where people can stay overnight. You cannot give birth and leave the same day if it's about bed capacity for those mothers. Secondly, there's an issue which was experienced by some staff somewhere where a staff in the level of town administrator in the county government who was admitted has been remitting their SHA, and then the hospital, which is a top hospital in Nairobi, a public hospital, says that this staff cannot be reimbursed at the level of what they call public service because they are in a different scheme, which is UHC. This staff is in the payroll in MPPD, just like the staff of the national government. We need to find out whether we could be getting a different treatment for our staff as far as claim is concerned, because these patients was told if you are public service, you'd have been able to reimburse up to 60%. But now because you are in UHC, which I don't understand because they're civil servants, you can only do 30%. So that is something that needs to be investigated because our staff in all 47 counties may be suffering from this discrimination. Now that there are so many uncoordinated policies that are taking place without our knowledge. And lastly, Chair, we'll give you 100% support in putting our foot down on the issue of locking out our staff from SHA claims by 9th. Today is 5th. I can guarantee you by 9th, we will not have gotten our disbursement. Our disbursement will come after 9th. By the time we remit, it will be around 17th. We will not remit less money for sure, simply because the date passed. But for the time when they have not been able to get our remittance, our people will be locked out. It is as if we have a date with when we have to get sick. If there's a way we can tell our people don't get sick during this period, then that will be easy. But diseases are there all the time. So why this discrimination? There's national government employees. Are they also being locked out? Of course not. So what arrangement they make? This is blunted discrimination, Chair, without even trying to hide anything. And it is robbery without violence. Because you pay the same amount of money that you would have paid if you got the services or not. And therefore, we should be able to put our foot forward, as all the collective 47 counties in the summit, and ensure that we get a fair claim on this. And I'll leave it at that, and hope to discuss the rest of the issues as they come. Thank you.
Yeah, Chair, I want to add my voice to what Governor Mudomi has said, to congratulate you on your appointment and say that we have confidence in your leadership. Number two, I want also to say something about level 2. I would like us in our statement today to say that all level 2 facilities must be treated like any other facility in terms of reimbursement. And that without that, we will go backwards in terms of managing issues of MCH, which is a core issue. And the truth of the matter is, for all the years I have been in governor, mothers have been delivering in level 2 hospitals, so whether there is a bed space or not. In fact, there is emergency resolution of problems of expectant mothers, even if they do not have bed space. And governors have been expanding these facilities to have bed space, even just for a place for a mother to rest after she has delivered. So that is one of the things that I think we should resolve. The second one is on the ambulatory services. If anyone wants us to use Uber-like systems in ambulatory services, we can still do it in the counties. If there is any support that the counties might not require in terms of ambulatory services, then they can give us a software that they want to use of the national system so that we can still decentralize, while at the same time making optimum use of the ambulances that are in counties. I think almost every county will most likely have ambulance services for every level for hospital. And those ambulances can still be summoned to move from any part of the county to the other. And if you want them to move from the county to the referral hospitals, what do the ambulances in counties do? They still ferry patients from county hospitals to referral hospitals. So there is no big deal about centralizing this matter that it can enhance efficiencies, unless there is someone who wants to benefit out of it. Finally, I still want to come back to what the CEO said, that it appears that when we put the issue of finances forward first, then we lose the point. We need to indicate the services that are required in the hospitals or in the facilities to enhance what you call universal health care. If we do that, and addressing the specific unique needs of the various diseases, especially the NCDs that have plagued this country for a long time, if we have got to solve the problem of malaria, if we have got to solve the problem of HIV and AIDS, and if we have to solve all those other conditions that are perennial in the counties, we have to focus on those by looking at the solutions and then now cost those solutions so that they can be applied by whichever sector of government. But mostly, all of it should be dealt, most of it should be dealt with at the council level. Thank you.
Thank you, Chair and Tim. I would like to start by thanking the Secretariat of the COG for doing a very good work. Honestly, in the morning I said, minus Secretariat, COG will have been just a shell. And it's also not, they are not getting a very good support from us as Excellencies Governors. In terms of subscription payment and even the legal payment. And one of the things that we need to address it in the next meeting of the Council of Governors, I think, should be how we're going to facilitate the Secretariat. Because a lot of things are happening, and we are very busy as Excellency Governors, and the other one actually is carrying the burden of the Council. On issue of UHC, I think we have been just been politicking for the last 3 years, honestly. And if we don't put our foot on the ground properly now, matters of health will going to come and consume us governors. Because when public being addressed by executive, they say the hospitals are free and people should be walking in and out of our health facilities, which is not the case. For example, excluding level 2 and 3 out of maternity is actually one of the worst thing which is actually doing from the Linda Mama, as you said. For counties in rural, the rural counties in the northern Kenya for that matter, in fact, we invested 70% of our health budget on level 2s and 3s because of the distance. For example, Mandera is about 260,000 square kilometers. I mean, 26,000 square kilometers. And referring all the deliveries to level 4, which are less than, I think, 7, which are about 7, is not going to make sense. What we have done as a county in Mandera, we had a special maternity wing even in our level 2 hospitals, so that our late mothers can now deliver to the nearest health centers. That's not even near compared to the world standard. We are talking about 10 kilometers, 20 kilometers to the dispensaries. And you cannot predict when a mother will going to deliver. So that you plan for her so that she can be moved to the nearest level 4 hospital. So if we don't handle this thing, I think we're going to fail completely. And already we are losing the gains we have already made in terms of scale deliveries, which is actually, no, we are not actually progressing. I think the purpose and the object of UHC is actually to devolve and decentralize health to the lowest level. So these issues should come out in our next Council of Governors meeting and then to summit, actually. The rest, I think, it was well covered. We need a chair also as the health committee because to support the secretariat, because this is a very, very important committee. And one of the reasons I actually said you should be proposed for the chair is you have done very well in terms of share registration. And later maybe you tell us how you have achieved the 70%, because some of us are still low. Otherwise, these issues need to be addressed, minus politics, because if we politicize health, and then we are doomed to fail. Thank you.
Now, colleagues, I think we've all stated problems, but none of us has actually stated a solution. What I'm proposing is something a bit more drastic. If you realize whenever the issue of being cut off is being addressed, they always say that it is because it is embedded in law. I'm proposing, because the major consumer of SHA is actually the county governments. And what I'm proposing, And I believe that by doing this, it will actually cause a bit of a stir. I'm proposing that our secretariat with the legal team to immediately come up with amendments to the SHA law. Because once that is law, one, it has to be embedded in law. What is the time frame that they're actually meant to pay? What date are they actually meant to pay? Two, what are the penalties? Because you see, when a person does not pay, there's a penalty that is charged. So in law, it is not going to be unfair for you to tell them that pay as well. So we come up and draft amendments that are going to be something that is going to be very, very shaky. The issues that are there is delay in payment. So we have to make it very clear that the same way they're saying that by 7th, by 9th, that there's a cutoff. Our proposal will be that within this period of time, the following 9th or the following 10th or the following 15th, they should have already paid to the facilities. Two, it also has to be very clear in that particular legislation. Because you see, they have a whole thing, the one for the digital health. But there's nowhere that talks about what happens when there's no connectivity. So we have to amend that law to include, I don't want to go to that example, but what is going to happen one day if they decide to shut down the internet? So we need to come up with an amendment to include as well that what happens in the event that for whatever reason there is no internet, and whatever reason that we don't have those. Three, in fact, it is already law. Whenever they want to be able to do any form of policies, they have to pass through regulations. The process of passing a regulation is that, one, a regulation has to be passed through public participation, and that means you involve stakeholders. Then those regulations are sent to Parliament. Now, all these policies that are currently there, not even one of them has passed through Parliament. And the reason why is because my feeling is that this law was actually passed extremely quick. It was passed so quick, and I think also we are also equally to blame as governors, because we should have realized this. Now that it is water under the bridge, we raise these matters? Yes, I remember. Yes. And then I'm also proposing as well that one of the other amendments that we need to come up with is it has to be very clear in law. What is the time frame for them to tell us that they've rejected us? And then after that, what is the time frame that a hospital can be able, a clinic, a hospital, or whatever, can be able to appeal? And then even after that, they have to give, in the event that the appeal did not work, we need to, the law has to be able to allow for an appeals board. And the membership of that appeals board should be with an equal representation of both the private hospitals, the public hospitals, faith-based hospitals, and the ministry as well, which is now the one that they're going to do. And then even that, we also need to be able to make it clear that every facility shall be given access to view their dashboard. Let it be in law. Because otherwise, whatever it is we are doing here is we're just talking about the problems, and we're just going to be talking amongst ourselves. And lastly, it also has to be very clear what level of hospital is offering what. Because right now they've told you that level 2 and 3, because they've already added diabetes on level 2 and 3. They've added hypertension in the lower facilities. They've removed maternity. I've asked my chief officers just to come, because the last time I was talking to them, they were informing me, I don't know whether they're around, but I think, no, are they coming? They informed me that some of the facilities, so we might also need to be careful so we don't burn our fingers. They were telling me that some of the facilities, maternity, they've accepted. But let us be clear, and I think this one as well, whether it is going to be through the caucus or the governors themselves to actually confirm and sign whether they've already accepted and this has been opened. Now, Mudami was talking about that, you know, the reason why national government are not cut off. The only reason why national government are not cut off is because national government, they pay their salaries before that date. So they will use that as a reason. They have indicated very clearly that unless the law is amended, they cannot do anything. The other alternative now is Treasury has to either give a guarantee. Treasury needs to give a guarantee. It's the only way out. An undertaking to SHA that we are confirming that this is going to be paid and people should not be able to cut off. The other issue that we also need to be able to agree on as well here now. 2 days ago, I was with the community health promoters in Mombasa. You know, they have accepted for some counties, they're yet to confirm. Mombasa is one of them. We've written to SHA and asked them that we need to be able to get a flat rate for our community health promoters. I don't know whether the other counties, I know Muranga was given a flat rate. For the community health promoters, Muranga was given, I think, a rate of 600 or something. How much? Yes, which I think was around 600. Yes, but some of us have written to SHA, they're yet to respond. You know, you've got the community health promoters who are your first people on the ground, and they themselves are not covered by SHA. So if they can be able to accept with what we feel is indigence on our part, and we include the community health promoters, that is not something that we can put in law, but that is something that we just need to be able to add on. And of course, the other one is we write to Treasury, and we inform Treasury that it is a decision of the council that all our employees, the health does not stop because disbursements are coming in late. I don't know, have they indicated when is the next disbursement lot? Which is the day after tomorrow, which is tomorrow, or last week, that never happened. There's an issue, we will need to be very careful when it comes to the ambulances. Currently, you've got the likes of Red Cross, then you've got the likes of St. John's, who are all currently running ambulance services. Let us also not end up looking like, you know, there's also that feeling, the perception out there that why did we never ever challenge? Because in Mombasa right now, and I'm sure in other counties as well, St. John has ambulances, Red Cross has ambulances, and I think a number in the cities, yes, there've been a number of people who have these ambulances. What these guys are proposing, I'm assuming that is what they're proposing, because you know they've said that they will showcase it to us before the launch, which they have not. What they're proposing is they have an app like an Uber app, and then thereafter, now if we argue that let that app be decentralized, they will tell you that Uber and Bolt is in Europe, and I think Uber is in America. and it can still be used in Kenya, and the Kenyans are benefiting. There is no other way to be able to decentralize. What we need to be able to ride on, my belief, is what we need to ride on is to ensure, because I was seeing something the other day that you said that our matatus, our ambulances are like matatus. So now you see they're going to ride on that as well, that we need to come up with a standardization of what an ambulance is. Now, maybe the Secretariat can be able to do something for us. Secretariat can be able to check for us what is the international standard of what actually entails to be an ambulance. They exist, isn't it? Yeah. So, one, is there any county that has met those particular standards, first of all? The part of the ambulance might be tricky for us to walk away from it, because they'll just come and tell you that all we're doing is doing exactly that you guys have admitted yourselves that your ambulances are not ambulances. We're giving you standardization of what an ambulance should look like and what it should be, one. And then they're going to tell you that the issue of an ambulance from Nairobi reaching Mombasa will not arise, because if an ambulance from Mombasa, or if an ambulance exists in Mandera, or if there's an ambulance in Baringo, then the nearest ambulance from the distress call is the one that will be able to reach that. The issues we need to start asking ourselves is, what happens in counties where there's no network?
We are requesting as counties to be involved in co-creating this idea so that we can give our input. Because most of the patients will be patients from counties, and therefore when they control it from Nairobi and license it from Nairobi, it means you can find an ambulance that is worse than the ones we are calling matatus licensed, which will be too late for you, and there's nothing you can do because you're not the ones who license them. They come and pick your patient. Sometimes maybe you're not there physically to say no. Your people may say it's better we move because there's no other ambulance available that time. Then they die on the way. It's even better if they were somewhere else. So we should be involved in co-creation so that we have levels, including in that vetting. Counties should be involved so that we can also, like the way we have a board where we have our own representatives, and we also make sure that what is going to operate in your neighborhood, there should also be vetting. Why should ambulances be sent to operate in Mombasa, cleared by Nairobi, and the governor of Mombasa has not been involved in checking the standard as well? That should be an issue.
I think what we need to be able to maybe put in is that when they're coming up with the standardization, the county governments needs to be involved in the standardization. The danger that is going to be there, I can assure you, you know the way the NESP worked, this is what is going to happen. What is going to happen is you'll get a number of people, because they've already made it clear that they're going to now throw it out there that whoever has an ambulance, this is the rate at which we are paying per distress call, per kilometer. Now, if we're not careful, what will end up happening here is county ambulances will now be sent to departments of veterinary and agriculture.
Your Excellency Chair, allow me also to congratulate you on behalf of the caucus. But this issue of ambulance is something we need to look at critically from the level of the counties. We must agree, all of us, that ambulance service is a devolved function. You know, the reason this function are devolved is that they can reach the lowest level possible. If we allow them to go back, it's going to cause more chaos, because as agreed and I've listened to Excellency the Governors present, each individual county is unique. If we are going to centralize these services, we are going to remove the uniqueness of individual counties, and we are going to have even more problems. Issue of ambulances, Your Excellency, let it be county-based. Let's allow counties to work with other partners they have in their own spaces to manage the ambulances. If they are managed from the national level, they are going to cause more chaos in our spaces, and we may not be able even to sustain ambulatory services in our counties. The reason why some of the counties don't have ambulances or the standardized ambulances is because we have lacked support. If we are going to get support from the fund, then I know even more counties are going to invest more in these ambulances. So if we allow that to shift, then we will be going backwards, Your Excellency. Thank you.
I just want us to be realistic on this matter, CEO and my colleagues.
Yeah, maybe what we can allow them is to inspect and then approve the ambulances we have, but manage it at our own level. Because I think the way the caucus secretary general say, for example, in Mandera, actually I'm in the emergency forum of my county. At 2 a.m. in the morning, in one of the rural area, we send ambulances to those places. We have about 13, and it can't even cover Mandera. So they can look at the specs, the standardization, approvals, but once approved, then allow us to run the ambulance services. I think that's one of the better options.
I just want us to agree on one thing. Currently, when it comes to a standardization of a hospital, we're all, it's what is in law right now. It's the KMPDC. KMPDC is actually national government. Constitutionally as well, when it comes to issues of policies and everything else, it is national government. You know, if we want to have an argument, let us have an argument that will be able to work. Because you have to understand that on the other side, those who are holding those offices are politicians. They're going to say that counties are refusing this because they actually do not have ambulances and they've just been using, you know, rickshaws. By the way, if you go to a county like Lamu, you know, a county like Lamu, I don't know now whether they have it, but before my advent into politics, I was more, I had an organization called the Sharif Nasir Foundation. I donated a tuk-tuk ambulance to Lamu. That was very, very many years ago. Because Lamu, there's no way for you to be able to use an ambulance. So it was one of those tuk-tuks, exactly. But that will never be able to move with these particular standardizations. I think what we need to be able to hit on more is that they involve us in the standardization. Two, they need to be able to tell us how this app is going to work. Because the other danger that is there as well, Mary, they can create an app. How do we know that that app will give preference to other players?
Yeah.
That's the catch. That's what they're doing.
Exactly, because how will we know? So what we need to do is we just need to be able to tell them this way, that we are supporting you, however, bearing in mind that the number of ambulances the county governments own collectively are the majority. We simply want to be involved in one. Let us prepare the standardization manual. So what entails for it to be called an ambulance. Two, the part that you're saying that we're having a platform, before they launch this thing or anything else, because first of all, they said they want to launch it when? Okay. Now this is where the danger is. If they want to launch it by 1st of December, by now they should have already made arrangements and asked for number plates and logbooks from all the county governments. Now if none of you has already been requested for this information, which ambulances are they planning for? Unless there's someone who's already imported these ambulances mysteriously.
Chairman.
Why don't we have Sang? Yeah.
So, Chairman, two things for me. First, congratulations for taking over the leadership. We as members of
Sang, wherever you are, Sang, we can't hear a thing you said. Maybe you want to repeat yourself?
Sorry, yes. Am I audible now?
Yes, yes.
So what I'm saying, Chairman, is that congratulations on your election as a member of as the chair of the committee. Two things on this ambulance issue. My thinking is that private sector, the inclusion of private sector to complement the public services is a good thing. I don't think that the ambulances that I have in Nandi County are enough. Even the ones that are being offered by private hospitals, faith-based organizations, they are still very few. And it is my thinking that these program on ambulance services must have been driven by the fact that we have that scarcity, or there is a gap to be filled in terms of ambulance services. So my feeling would be, as county governments, we just lucky ambulance services. Initially, I had gotten indications as if you have to make a choice to avail all your ambulances to be managed by that program, and therefore they are not within, your directions. Or then if you retain them in your facilities, then when you move a patient from one facility to another, then it means that you are not covered under this fund. That for me would be a challenge. If it can be confirmed that my ambulances, when they are used by our patients, then I can be reimbursed. Or other times when they are being used, when another patient needs an ambulance and there is a private sector ambulance that is available, if that is the nearest ambulance available for the patient, I think I should not have a problem. So my thinking is that really it would be difficult for us to crowd out private sector investment in the ambulance services. Through the standardization, again, I don't think that it is something that we can give. I mean, it's a professional work. We should be able to allow, whether it is KMPDCU or whichever body that is supposed to do the standardization, then it is the responsibility of counties to meet those standards, and then your ambulances are plugged into the whole infrastructure around ambulance services. But I can say for my county, I have, I think, about 15 to 20 ambulances, but the need, the services required we can't be able to meet them. So welcoming private sector into the ambulance services provision in the counties. Of course, using an app, technology is the way to go. So we just need to know what is this application? How do we create synergy with the technology being used, being offered? So I just want to be practical. I think I'm more inclined to what the chair is saying. We must just be realistic about this so that we don't appear as if we are just saying, no, we do not want this whole, new program around ambulance services provision for the sake of it. We just need to ensure that our ambulances, the provision by county governments, ambulance services are covered by this program. Thank you, Chair.
I think we need to be able to make a bit of progress on this. My proposal is, and I want us to agree on one thing. this is something that the public will really say that it is an amazing initiative. So how we communicate on this, let us be very careful on how we are going to communicate on this. Because if we're all going to communicate on this and say that we outrightly do not want it, politically this is going to hit all of you, because you'll be told that ambulances are going to be available on phone. Why are governors saying no? I think what we need to be able to do on this one is we insist that we need to be able, and we also raise concern that we've heard that this is coming up on first. We are the ones who own majority of these ambulances. We're yet to be informed on what is needed on our part, and we're the ones who own these ambulances. Two, you know, this is another issue that we also need to be able to agree on. You know, ambulances are not registered under the name of a facility. Ambulances are registered under the name of the county government of Mombasa, or a county government. How do you receive that payment if that fee is not in the Finance Act? Every county has a Finance Act. The reason why the facility improvement is very clear, so that means now all these payments go directly to a facility. An ambulance is registered under the name of a specific county government. That means that money has to go to the CRF. You know, these are the issues that they need to be able to, how else is the money going to come in?
I think from my understanding, Your Excellencies, it could be an amazing program, but remember, any amazing program would only die if there is no information to the people that are concerned. One of the things that we should be demanding from this meeting is that there has to be kind of a presentation on how the ambulance program will be run, so that all these ideas that we have can be addressed on a sitting. From what I can remember, there was a program that was being advanced by Vodafone. It's called what? Vodafone. Yes, M-Mama. It was being called M-Mama. Where they were proposing, you remember, where they were proposing to have a pool of ambulances that they can actually avail to counties. And this was in the advent of SHA. What there is right now, Your Excellency, ambulatory services are actually covered under the tariffs. So if there's a service that has been dispensed through the ambulance, it's just paid as a service you claim. The same way we are claiming the claims from the hospitals. Now, the danger that we may have is we have actually commercialized most of the health services. And if you look at it very critically, even this one is commercialization, which means whoever that is offering these services will have an upper hand because it's already covered for in the tariff. So reimbursement will be very easy. Now we have our person that sits in the SHA tariffs and has the knowledge about this program. Can you allow Robert, just 1 minute, to shed more light on this, kindly? Robert.
Robert, are you online?
Yes, I'm online.
Yeah.
Yes, I'm online. I'm following.
Proceed.
Sorry.
Proceed.
See, okay, maybe on the issue of ambulance, my take on this, or rather my view on this is the way SHA fails to communicate appropriately what exactly an ambulance system they're rolling out is. Whatever they're calling a dispatch center at SHA, it's really not a dispatch center. That is a pre-authorization center. The same way for facilities, the only person mandated to do pre-authorization for any service is SHA. So if you were to have, for example, 47 county dispatch centers doing the work that SHA will be doing, it means SHA will be giving the counties the work to do pre-authorization for that service. So you can imagine as a payer now as SHA, you get 1 million claims that you don't know who authorized them. So I think whatever they're doing at SHA basement or rather the dispatch center is a center to pre-authorize. So, and then two,
the ambulance they are contracting, they're only contracting for emergency services. So we have emergency and we have referral service. So emergency service is what has been now included in the benefit package. For referral from facility to facility, that is not yet into the package. So our issue should be, can we also include referral so that we are doing emergency evacuation, what has been included, and also do referral service. But referral as at now is not yet a service that SHA is covering. That's why they're saying for facility to facility, they're not doing it except maternal services, which SBPF has purchased for them. So I believe our focus should be how do we enhance the ambulance service and not rejecting, but how do we make it work for the facilities? Because now the people, Kenyans are paying for it out of pocket. People are paying fuel and all that. And then the final issue, with the rate of 4,500, I think it's a good one for the county, because any ambulance in Mombasa County, for example, if you are to call AA plus AMREF, whichever ambulance, it will not be less than 15 to 20,000. So if we push, for example, for increasing that figure, it will incentivize the private sector to come in with ambulance. I will be able to buy an ambulance and bring it to Mombasa to do business. But with the rate 4.5, it works for the counties because there'll be no incentive for private sector to come into this because it doesn't make business sense for them. So I think that's my take. Thank you.
Then in that case, Your Excellency, as a way forward, can we urgently request that SHA makes a presentation before 19th, so that we build a case for the governors by 19th, because we have a council meeting on 19th, the symposium, so that we can be able now to, authoritatively say that we've evaluated this, and these are our proposals.
I agree. We go ahead and we ask them to be able before that to do this presentation on all these matters, and then we raise the issues at hand, how this system is actually going to work, and before we can be able to do anything else.
Chairman, I think that is the direction we should go. And we would like to have a distinction between emergency services and referral services. A lot of time, the referral services that happen in counties are in twofold, where the doctors have realized that they cannot be able to manage to treat a patient, and they want to refer a patient to maybe a level 7 or level 6 hospital, and that happens frequently. In my county, we refer patients to Eldred MTRH. Also, on the other hand, elective referral, where the patient's caregivers feel that they want to go to another hospital because in their opinion, their patient is not getting the care that they want, and they have the money, so they elect to be referred to another hospital. And that's also the ambulance needs that can be there. So there is emergency ambulatory services where perhaps there is an accident somewhere, and they need to be ferried to the nearest facility, or to the facility that we think can be able to deal with the kind of emergency that is there. I think that is the presentation that is it SHA or the ambulatory services want to make, so that it is clear to us, and how to deal with all those kind of 3 referral services. Thank you.
Thank you. Can I proceed?
Yeah, go ahead. Robert, can you hear us? His mic is off, or has he been muted?
Yes, I can.
Yeah, go ahead.
I can. Sorry. You asked a question, please?
Governor Mudomi was asking about the revenue sharing of...
For the ambulance.
Robert, we wanted you to shed light on the question by Governor Mudomi on these county, the issues of reimbursement, the 60% of the employees that are admitted in hospital, the SHA claims.
Okay, so like for the case that you shared with, the county staff that went to ambulance, I had a similar case like 3 weeks ago, where a friend was admitted at Kenyatta Hospital, Prime Care Center. So she had a similar issue, $500,000. They only paid to 20%, around 20-30%. So when I followed up with them, they told me, unless you are under Civil Servants Enhanced Scheme, that's why you get a comprehensive cover. But if you are a normal SHA paying member, irrespective of how much you are paying, SHA will only pay what is in the tariff. So, for example, if you go to a facility and your bill is 700,000, and the things that SHA will pay, you only pay a portion of it. They won't pay everything. But if you are under Civil Servants Enhanced Scheme, the one that they're telling county governments to
I think we have a serious problem in this.
Enroll. So if you are under that scheme that is enhanced, you are paying more than the normal contribution, then now that's where you get a comprehensive cover. But for the rest, you only get a portion of it, or whatever is a pre-approved. So that's the reason why they're unable to cover everything. And also, if you go to the private center, the prime care, also they don't cover.
Then how is it an universal health coverage? If a county is
everything in the prime care center.
Through your salary.
Thank you.
Yes, we need a clarification from the SHA. I do not know whether Gerard is still with us, our representation on the board of SHA. And he's noting the issues. If not, someone should note it for him. Not just Gerard, but also all those who represent us there. And maybe Secretariat, once in a while, you should arrange a meeting with this representative with the Committee of Health, so that we can they can be part of this, not just virtually, but physically, so that they can have the feeling of our feedback on these issues. It is better than when they just sit, because sometimes when they sit with the other board members for some time without getting our feedback, they get carried away by a sense of belonging there. We are just making this work for the country without realizing that the people they are representing are being oppressed by the system and the same policies they're making, which are supposed to serve us. So we can continue with the next presentation. But Gerard, are you there? He dropped off. Okay. So Katra, you can continue the next presentation, or the issues you had not presented, because we intervened halfway on the issues that were very burning and emotive and could not wait. Okay. Okay. That can be done by another somebody else.
See, just the way you've mentioned, I had a conversation with those who sit in the board, especially for the SHA, and we were supposed to have a meeting between all those who are representing us in the SHA, in KEMSA, and also in the digital health. That meeting was supposed to happen 2 weeks ago, but unfortunately we had other emerging issues, so we had to postpone. But it is in pipeline, and we are going to have that meeting, Your Excellency. And then, Your Excellency, before I proceed, again on ambulance system, I think, as much as I'm not overruling what you've said, but I think national government should just be able to strengthen the existing dispatch centers within the counties, because already it is difficult for a patient to be able to say that I have a chronic illness, because what is the chronic disease? Nobody is taking them through awareness, categorizing for them that this is the specific disease that you have, which is chronic, so that you can be able to call an ambulance, it can be dispatched. So it is quite difficult. In terms of awareness, we already have a gap, even in the major referral system. A mother probably who is almost delivering, and she just shows some signs of probably something called show. Like before they go into labor, in the process they may see something like a blood, we'll obviously call an ambulance and say, I'm bleeding. So there are so many things probably that we need to rectify, but the issue of actually decentralizing, centralizing ambulance dispatch centers cannot work. It will never work. It is just that they need to basically give the counties that funding because already referral system is established within the counties. Probably we can also advance that conversation if it is going to be workable, unlike having it centralized. So, Your Excellency, our next agenda item is on National Equipment Service. I'll just take you quickly through. The reason as to why we had this probably is we are transitioning also for an MES equipment which actually expired, now to NESP, National Equipment Service, which is done jointly by both levels of government. And this actually aims at improving healthcare by procuring essential and advanced medical equipment for public health facilities through mechanisms like fee for services and framework agreement and placement models. So in terms of fee for services and the equipment that have been put in place, so far 41 counties have shared their medical equipment service need, but only out of the 41, 31 counties have received the same equipment. And we have an annex that is actually showing that. Probably it is in your file, but after this, I think we can also be able to project. And then the deployment and installation of the equipment is basically slow. To date, only 58 county facilities have received the equipment, and that is actually under NESP Annex 2. So cumulatively, over 74,000 diagnostic services have been rendered, but no county facility have so far disbursed funds to the NESP special purpose account to facilitate the payment to the vendor, which is also a big, big gap. As much as the placements have been done, even for those that have received those equipment and offering already the service, the existing services, still there is a gap in terms of doing reimbursement to the vendors through SHA. So in collaboration with the Digital Health Act, a digital workflow system, that is vendor equipment management system, has been developed and it is ready for rollout to all implementing facilities to enhance accountability and real-time visibility. Probably the CEO will be able to shed more light on this, but that is the current status in terms of NESP, and our recommendation is county facilities to ensure that there's disbursement of funds from services that has been rendered since inception to NESP SPA. Your Excellency, 74 million cumulatively is not small amount of money. And probably if these debts are not going to be paid, then that means services will still be paralyzed because these people obviously will stop offering those services. Then digital health also to expedite training of facility personnel on the system of the vendor equipment management service.
Yeah, Katra, just there, what is in record is not 74 million, but it's 74,000 services, which could be more than 74 million.
Yes, 74,000 services. Sorry, and
which
thank you for that
have
correction.
not indicated the
Excellency.
value. That is what would translate to how much is not paid to
We have
vendors.
that figure. Maybe, Jemima, you can look at it. There is a figure that we've basically put there. I don't know whether it is in the next presentation, but there is a figure that we've put there, which is close to a lot of money. As my colleague will be able to look at it, because I can proceed and we can get the figures because basically we had that figures. So Your Excellency, out of the equipment that have been placed, we still have a gap in terms of one placement, which was previously under MES that expired. The central sterilization centers, which are supposed to be sterilizing this equipment, and that is basically missing, and there is no active or current vendor, current vendor who is basically pursuing that, because right now what is happening is just the facilities are using the existing sterilization methods that they are previously using, but these are basically heavy equipment that require a whole central sterilization center with bigger equipments to sterilize those equipments. So the other challenge, Your Excellencies, are financing model for level 2 and 3, which has not been activated. Remember when we started this thing, there was an issue of 30/70, which has never come through for the level 2s and the level 3. So right now the equipments are placed at the higher levels of care, which is level 4 and level 5. But we still have a gap in level 2 and 3 under the other framework that was supposed to be activated. The other challenge on NESP, Your Excellencies, are slow distribution of equipment by vendors, because the demand of the equipment is exceeding the supply. And counties have basically put a lot of requests in terms of equipment, but then they cannot be able to receive that. So it seems that the demand has become so high, but then the suppliers have actually, I think the expectation was not that, so there's a bit of slow in basically procuring those lists that was requested for by the counties. So the outstanding payment for services that was rendered, Jemima, you can still get me that figure. I don't know where it disappeared. But then the other major gap, Your Excellencies, that we are having is the training of health facility personnel on the digital flow. Remember we said there's supposed to be a system now that will be deducting this money directly once they offer the services. As much as that digital system and everything will be installed, then there'll still be a gap, because the personnel have not been trained, and so they cannot be able to use that system. So, but I know by last week or this week, there was a conversation that was ongoing, and that there was need for the staff to be trained, and they were basically requesting for the list. So also, primary health services are not integrated into the digitized payment mechanism. Probably once we activate and it kicks off, still then there's going to be a gap for the primary healthcare services, because then that means there's need for, again, healthcare workers to be trained, or not the healthcare workers or the engineers, the medical engineers that are working within the counties. There is also non-utilization of the installed NESP equipment in county facilities, and there are counties which NESP equipments are not offering services. Probably we can also be able to give this data. And remember, this is also what we experienced during MES equipment. Equipments have been placed, but some counties have not been able to initiate as a result of some gaps. Majorly under MES, it was the issue of three-phase power, and also the issue of skilled personnel to be able to operate the machine. So it may not look very good when we have an equipment, but then when we are not using, because remember, these vendors also place there those equipment so that they can be able to be paid. So one of the recommendations under this is national government to activate the equipment financing for level 2s and 3 and urgently contract a vendor for CSSD. Because these are major equipment, major investment, there is need for sterilization. Major equipment also for central sterilization centers. Then there is the Ministry of Health also to rationalize and fast-track distribution of equipment as per the county requisition. Vendors also to fast-track delivery and installation of equipment into the counties, and digital health to expedite training of health personnel on the digital flow. That is one of that is majorly for the NESP equipment. Maybe the CEO can shed more light, but those are the major challenges we are currently facing, Your Excellencies. And I know some counties have also called in terms of like getting those equipment. Some of them are saying as a result of delay processes, probably we may procure our own. So there are a lot of challenges that basically need to be addressed. And then there's a whole team calling Project Implementation Committee. Our CEO also sits in that steering committee. Probably whatsoever can be raised can be able to be escalated to the Project Implementation Committee so that it can be addressed adequately. Back to you, CEO.
maybe just to offer two clarity on what Katra has spoken about PHC services. If you look at the tariff, the benefit tariff, it has provided just a bundled together tariff, and for that reason, SHA does not recognize primary health care, the X-ray, that is a lot 1 X-ray, ultrasound, and lab services. They're actually not covered under SHA. So they're saying for that reason, the counties will continue reimbursing manually, as opposed to the model that we adopted for level 4 and 5. So which becomes now a problem for us, because the vendors will not actually have economic value for their money. So this is something that is a risk moving forward. Then the slow pace of placement of these equipments and at times, the uptime. In terms of the quality of machines, I know we have 3 cases for CT scan, Mandera, Kisii, and Tharaka Nithi, where that machine, I don't know what had happened. So there's need for us to raise it now, so that if it's not working, then they need to, change. Then the slow pace of implementation. We have one service provider that does the MRI that has not even provided one equipment in any of the hospitals. So remember, counties have not budgeted for that service. So it's a problem, because we thought that they would place. So I think those are some of the issues that we need to raise moving forward. Then number 4 is the challenge now on the county. There are counties that equipments have been placed, but the CECs and the chief officers are instructing the counties not to use that service, but use other machines. So I think, from onset, if you don't really want, you don't place a request, so that it's not a waste of resources from the vendor. So this was just an update of what is happening. Thanks, and over to you, Chair.
The structure, and we have been coordination, they have been coming there. So they have not yet imported any MRI machine?
The vendor is non-responsive. He's not placed even a single machine. We wrote a letter to the ministry so that they terminate the contract, but it's yet to be terminated. So he's not supplied any machine.
CEO.
Are they the same guys who have been sending technical people to come and assist us in how we're going to set this? Yes. And supervise even the structure?
So the vendor that we were counting on, Governor Mandera, has developed cold feet. So even the issue of coming to supervise the structure may be an issue, because he's not planning to do the same. So Governor Sang, you can take the floor as I hand over the mic back to the Consultative Chair.
2 things, Chairman. Whip. On MRI, I met with the vendor, informally, and the vendor was raising a very valid concern. He said that the specs that were the specs of the equipment, the MRI that was awarded to him, when he does the simulations and looks at the potential of each of the counties, only about 12 counties would qualify. Because, the whole story of how much you are able to charge and how many patients or scans you are able to undertake for it to make business sense for them. And they seem to have been indicating, because I was pushing for my county, they said, your county, if you look at the numbers and everything, you cannot, the specs of the equipment that was given will not be viable in my county. And that they had made a recommendation to the ministry to allow, to consider either a lower specs machine or, think of another way forward. So that is a matter that needs to be taken up. And I took up with the president for my case in Nandi County. And we were saying, because right now we take our patients all the way to Eldoret and back to Kapsabet. The cost of the ambulance services alone of taking a patient to go and do an MRI in Eldoret and come back to Kapsabet is not practical for us. So that is an issue that we need to look at. So we need to understand why is it non-responsive and explore those options. But the second question that I had, Zombie, you remember there was another set of medical equipment where we were supposed to, pay 70% and the national government pays 30% and it can be staggered over a period of time. What became of that? I remember the last time we were at State House, there was a discussion to the extent that there was evaluation on that potential, service. So do we understand where we are with that particular one for the smaller equipment? You remember that program?
Chair, can I answer that? I'll take silence because you're seated next to me as yes, Chair. Yeah, so the issue of 70-30, Governor Sang has already been alluded to by Katra when she was doing the presentation, but the CEO can give us an update on whether we have had any engagement from national government, because as far as I'm concerned, there has not been any county that has been able to implement that. Of course, it means that the national government must be ready with the 30, because that has to be the deposit, then allow you as a county to pay the 70 on an arrangement. So there has to be some framework that allows you to do that, and we have not seen anything, and we should be able to push that from our side. Mary, if you have any update on that, you can give us. On the issue of MRI, Governor Sang, you didn't tell us whether you eventually, after talking to the president, whether you succeeded, because there is no need of reinventing the wheel. We would like to know from your side, if you succeeded in that, then that should be the solution to most of the other Kapsabets, which should be more or less the other 47 minus 12 counties that cannot be able to benefit from the bigger scale of what has been ordered at the moment, so that we can take a collective position of those counties and push for implementation. Because definitely, the vendors cannot be forced to place equipments where they're not making any business sense. And if there are MRIs that are of less specs, which can do can do the basic diagnosis, then they should be allowed if it makes business sense for them. Case in point, should be the MRIs that were there in MES. How are they working? Are they still working? And what were the specs that time? Again, that is to you, CEO, because that gives us a starting point on where we can base our case on. The MRIs that were there in MES, were they working, and are they working in those counties as they were? But I believe there were very few also, and they were not in the MES. I think it was separate. It was a separate arrangement, so that we can build on the successes of the same. Over to you, Chair.
Actually, three issues that are going to go hand in hand with this. The first one, we need to be able to get a confirmation from every governor what and what equipment has not been supplied. Which equipment has not been supplied in which facility. And after that has already been done, the second part that we also need to be able to agree on is we need to make a decision. I don't know the contract that was signed between the team that advertised, whether there was a clause that in the event they don't deliver within a certain time frame. So if that clause exists, then we need to be able to invoke that clause. Because as we speak right now, some of us have facilities. I'm sure a number of you are building new facilities. There's going to be a demand for this equipment. Some of this equipment, if counties are going to be just left in abeyance, then it becomes another problem altogether. Because the time of ordering some of this equipment will take quite a bit of time. So you're going to have equipment that is not being supplied, facilities without equipment. The public will not understand the arrangement that is there. But then over and above that, there's something else that I don't know whether we have not seen the direct nitty-gritties of it. You know the issue of deducting at source for the services and deducting at source for KEMSA. And you know, deducting at source, what they were proposing, that whatever it is that is meant to be, if we use an MRI, they just deduct it at source. Right now, if you don't even have access to know how much is due to you, and then they go ahead and tell you that they've deducted, how are you going to be able to tally these figures? But you know, the way goalposts have been changing left, right, and center, I think we need to be very clear that the FIF, can we also be able to check the FIFs whether there is a provision that you cannot deduct at source? And if it doesn't exist, we also seek to put an amendment, because if they try to do it now, they can try and do it tomorrow. That we put an amendment to actually say that you cannot deduct at source, because if they've tried to do it,
the training that is ongoing is after the county attorneys were brought on board, they realized that that money could not be deducted at source. So what happened is they retained the autonomy of the facility in charges in terms of authorization, so that they're in the loop of what is being paid. So this trigger will be after they analyze the service for it's coded. Each service is coded. But after that, they will forward all these reimbursement per county to the facility in charge to confirm first that these are the services that were rendered using the FFS machines. Then he gives an okay for it to be deducted, to be split. Actually, it's not deducted, to be split at that point. So SHA cannot do it on their own volition. It is the in-charge facility that will confirm, depending on ascertaining that these are the services that have been rendered using the FFS, these are the services that have been rendered using the county machines, and at that point, they authorize for the split of the monies. So that is it. Number two, on what the whip had asked about the service, and Governor Sang, about the CSSD, the service that was on leasing. One of the things that we've brought about is the theaters have already been equipped. I think this week, there are 124 machines that are being sent to various hospitals that are demanded. So meaning, theater machines are available, but the service on CSSD is not available because it was stopped. So that's why Governor Sang was asking the leasing component that was, what is the position as it is right now? We had a conversation with the PS on Wednesday on Wednesday, on how to actualize this, because theaters are going to grind it to a halt. And from what I gathered informally, is that they may be considering a budget to actualize that service for purposes of operationalization of the theater. But this is very informal. It has not been confirmed. We have a meeting on the 11th, the steering committee, so that we see what happens moving forward. So that is a position.
You know, Chair, having theaters without CSSD is like saying we can have a milk processing plant without sterilization, or rather having to, what do you call doing that? What do you do to milk? Pasteurization. It's not possible, because CSSD is so critical when it comes to operations, because it's one that creates the germs-free environment. And most of the theaters, if they're not able to afford that locally, then they are just doing it, Juakali style, which will increase the number of aborted operations, which is not what the result we are looking for, Chair. So that should be given a very special consideration and pushed for a solution. Thank you.
Solution. I would strongly propose whether even before because the team that was, because there was a team that was meant to be going through, that the technical team on the issue of the NESP. If they can be able to give us a report one, what happens in the event that a vendor fails to be able to comply, and what are the time frames? Two, what is the status of, what are the vendors saying about the other equipment? And if it is acceptable, then we now throw it to the full council and make the council make a decision whether every governor should make their own arrangements, or should we be able to see what needs to be able to be done. I don't mean to throw a spanner in the works, but can I ask one question? What stops us as 47 governors to bypass a national government and decide to advertise on our own?
Nothing.
No. You see, the whole concept of doing this NESP was economies of scale. I remember when I wanted to do this, and Mombasa had to drop because Mombasa was going to have more numbers than others. In fact, I think right now there are 2 counties that are holding the highest numbers. It would probably be Mombasa and Kiambu, because Nairobi did not sign. You did sign eventually? Okay. So now these 3 counties combined are holding the numbers. Exactly. So what I'm saying now is that what stops us? Is there, because if the legal framework was there for us to be able to involve the national government on this, the Council of Governors is an entity.
The reasoning behind Your Excellency was actually the financing component. If you look at what was provided for leasing, is the national government was willing to cough out 30% of the total costs, then counties were to do 70%. So I think that's why we agreed on that modality and that arrangement.
But you see, this was even an agreement that was done at Summit.
Sorry?
This was an agreement we had agreed with at Summit.
It was.
If they've cancelled it without even notifying us, what does that translate to?
We raised that concern. It was wrong because it was a joint venture. That was wrong. So I think they have to go back again to drawing. But those are some of the things that now the committee needs to be aware about and see how to
What was the reason for the
forward.
cancellation?
They said that it was change of technology, which we did not understand, because there was nothing that was already provided to indicate that there was need for change of technology.
Because we were only leasing equipment where those equipments were not viable for pay-per use.
Yeah.
Isn't it?
Chairman.
Yes, go ahead, son.
You may just need, on that particular one, reach out to the peers. I got back to the vendor a few minutes ago, and apparently he was with the peers over the same. And I think that decision has not been made. It may require some bit of pushing on our part for the options to be provided. But we definitely need to make a decision either way.
What they had proposed is that whatever it is that we resolve here today as a committee, the issues that we have, they propose that we now inform them so that when we sit down with them, they now thrash out all the issues that are there. Is it in the committee's wish that this becomes one of the issues that is there, and we, as early as next week, because then after that, whatever it is we agree with the ministry, we will have to now sit down with full council, and then thereafter make it an issue to be or not to be in the summit. If we are able to thrash out the issues early enough. So can we agree that we add this as well, the issue of leasing of the equipment, why they did it, if they did not inform us, because right now then it seems like there's also, Sang is just that he has access to the PS and the vendor, and the vendor says, no, it's not been cancelled. Yes.
The information here, the letter. Leasing
Sang,
has
can
been
you hear that?
cancelled. What has not been cancelled is the MRI, the vendor that was to supply MRI. And the reasoning that Governor Sang has given is very valid. Then we need to be asking, because he's not able to do it because of, maybe it doesn't make an economic sense, then could we consider it under leasing? I think those are the options. But for leasing, it was cancelled.
You have the paperwork to show that?
Yes. I can give the letter that's cancelled.
Sang, are they hoping to backtrack on that?
It is. But what I'm saying, what I was proposing, is that for my county, because I am suffering taking patients, Eldoret, an ambulance, which, you know, they have to pay for an ambulance service to Eldoret and back just for MRI. My proposal is that I am willing to work with a lower specs, you know, which is exactly the same machine that we had before in the, you know, in the previous arrangement. It may not have been doing everything that we would have wanted to do, but I think it is better. It's still better to have that equipment or that machine in that smaller, you know, specs that we are able to service and we are able to, and it makes economic sense for the, you know, or that second option of a leasing option is still okay. So I think either way, a decision has to be made. And I think that is what we are saying. We must give our, let's have the options available, let the decision be made. Then we, if it needs to come back to the council for decision or counties to give their input, some of us are clear in our minds, we need the machine immediately because we are currently, you know, spending more. Yeah.
I've just been informed it is not the leasing that has been cancelled. It is actually the framework contracts that have been cancelled. So I think you are actually on board. You can, and what you're basically saying is that you don't mind the inferior version of what is being proposed to be upgraded because the cost of upgrading is an element of that will take a lot of time. So you're saying that you're content with having that inferior part going on, isn't it? I don't want to use the word inferior, but less superior.
It is exactly what we had with the previous arrangement. So I think there was an intention to go a bit high tech with a new program. But if the numbers of a county like my county does not support, then we just proceed with what is available.
Then supposing we consider it because it does not make any economic sense, could we propose maybe leasing, which would be more accommodative to the vendor than this, that we maintain the highest quality in terms of service provision? It's an option.
Well, it depends.
Absolutely.
I think it will also depend on county by county because some of the urban counties might need something that is a bit more sophisticated. Can we agree for this particular one, we allow a specific time frame where every governor can be able to now confirm whether they are comfortable or not comfortable. Then the governors can sit with their technical teams and revert back on that. Is that fair enough? Good. So, yeah, we'll get there. So can we be able to agree that is done? And then the other issue that is there is the issue of the state of the equipment. We'll ask the Secretariat to revert back to us what the contract says in regards to supply, when the supply was meant to be, and in the event they don't supply, what is the status of that is meant to happen. And thirdly, I think he was asking about so we will, you've heard what basically is, so if a governor is content with it, because they'll have to pay 70% of it anyway. 30% is what is being paid. Is it vice versa? Yes, yes. So we're done with the issue of NESP? Good. I'm going to, because the next one is the issue of health financing, isn't it? May I make a suggestion, colleagues? Actually, you were seeing me rushing in and out. There's a small emergency that I also need to be able to attend to. In fact, I'll need the guidance from the CEO as well to allow us to use that during our lunch break, and then we can come back. Will that be okay? We take our lunch break now. I just need to be able to ask you on some issues, and then we take it up from there. Is that okay? Thank you very much. Yeah, we had even agreed that we were going to call them in.
Yes.
For them, maybe she can just quickly say it. But then, Rosalind, can you hear us? Her mic is off. Yeah, Rosalind, can you hear us?
Yes, I can hear you. Excellently.
Rosalind, the issues that we have raised, we are going to be asking yourself and the other board member, Gerald, to come and we ask on these matters. But the issues that were asked was the issue of goalpost shifting, the issue of status of disbursements, and then also the council will be seeking your support. We are going to be proposing amendments to the law to allow that refunds, all these issues that we're asking should actually be embedded in law. So we're going to be asking for your support in this matter. But maybe I allow you just a few minutes just to speak, and we can be able to break for lunch. Go ahead.
Waziri, can you put on your video? I'm being requested.
I can. Luckily, I can office. I don't know if you can see me.
Okay, yeah.
Yeah, so, Katra.
Waziri, proceed, we can hear you.
Okay, so I don't know whether Gerald is on the call. Could you first of all confirm, because he's one of the chairs of our subcommittees.
Yeah, we heard Gerald this morning, but probably maybe you can just answer a few that you are in touch with, and then the rest maybe we can be able to have a conversation through the chair.
Okay.
I think, Katra, the mood of the members, because you see, we started the meeting a bit earlier. I understand maybe you had a bit of commitments yourself, CEC, but the mood of the members is the issues that were raised actually are quite pertinent, and we were hoping that you'll not be able to exhaust them all online. We're hoping that we can actually just sit down with yourself together with Gerald, and we tell you what our proposals are. Amongst them is to actually amend the law, so we can no longer have these issues of goalpost shifting, this changing, and this, one was the issue of delaying disbursements, two was the issue of inaccessibility of seeing what your records are, three is the issue of rejections being so high, four is what level can we be able to appeal on those particular rejections, the issue of maternal payments, whether level 2s and level 3s can be able to get it done, and if it can be able to be done, roadside declarations without informing the council. We don't know whether you guys sat down in the board and agreed on these matters or not. And then, of course, there's the other one, which I don't think will be within your purview, but the issue of locking out staff after every 9th, it's law. So I would not even ask you to be able to break that law. That is something we'll need to take up with Treasury. They have no capacity to do it. But the other issues, are you guys part of these discussions whenever they happen?
Thank you very much, Your Excellency. First of all, let me apologize. And Katra can back me up. I was not aware about this meeting. Otherwise, I would have prioritized it. So that is number one, my apology.
Thank you.
And I was called just a few minutes ago and I stopped what I was doing to come and join you. So kindly accept that apology, Your Excellency. Then the second bit is to clarify or to confirm that my role in the SHA board is actually to represent the other 46 or the 47 CC members, who obviously are the service delivery voice on the SHA board. So my role and that of Gerald, and obviously Gerald represents the council in its entirety, is to buttress some of these points that you're raising. We've actually been the voice of reason in terms of getting the board to see the practice or the granular level implementation challenges in the rollout of SHA. So I'm not trying to say that there's an us and them, but we're always the voice of the 47 counties. So that is the second clarification I wanted to make. The third one is to confirm that indeed some of the issues that you have raised, and obviously I won't get the opportunity virtually like this to go through them one by one, we have been raising them. Indeed, one of the ones that has been very dicey for Gerald and I is the issue of this you called, Your Excellency, and I'm going to use your own words, the roadside declarations or these declarations that are made, whether it's regarding maternal death and what to do with the facilities that are generating these deaths, or it's to do with the walk-in, walk-out and no payment and arrest orders and all that, some of which obviously His Excellency the President made whilst in Nakuru. We've not had the opportunity to sit and discuss them at the board level. What I think would be useful, and this is my suggestion, is to have a council level conversation with the CEO at the management level. That would be my persuasion, because some of the decisions are definitely at a granular level. For example, if you think about, and you just mentioned it, about accessibility of the portal. The portal was just brought down. I'm also a CEC member for Nakuru. And initially, we used to really benefit from having access to the portal. It's no longer available. Even concerns about the delays in disbursements, we ask them not as board members, but as members of the Council of Governors. So I'm with you 100%. Whatever support, not even support, whatever directive it is that the council is going to give us to pursue within the board, that is exactly what we are going to do, Your Excellency. Thank you. I submit.
Rosalind, just one point of clarification. When you started, you said Gerald is representing Council of Governors and then you're representing CECs. I thought CECs were part of the they serve at the pleasure of the governors. So maybe just a point of clarification there. I hope that when you guys go to the board meetings, you don't go with serving different parts where one is a council and then the other is the technocrats. Yeah, but maybe.
No, Your Excellency.
Good.
No, Your Excellency. That was a wording.
Okay.
If you read the law, I mean, it says there shall be a representative of the council coming from the 47 CCs.
All right.
But we take instructions from the council, Your Excellency. There's no doubt about that.
Thank you.
And there's no disjointedness between Gerald and myself.
I'm glad that you've actually confirmed that some of these declarations are roadside without them passing through the board. And at the same time, you've equally raised issues that some of the issues you've raised them at the board. And if you've raised them at the board, that means whether the board votes or doesn't vote is something else. Maybe before we meet the ministry and the SHA team, we will ask them to sit with us first. So we will raise all these issues, we will advise you, start preparing yourselves, and then when we come, even if you give us to the nearest detail, that on this particular meeting we held at this date, we raised this matter, on this date we raised this matter, on this date this matter was voted on, and what they're doing is contrary to what was agreed. So that when we meet with the CS and the PS and the head of the SHA team, we actually go there on an informed perspective. Is that fair enough? Is that fair, Rosalind?
Fair enough, Your Excellency.
Thank you very much. Asante sana. Can we agree?